Hi, I'm John Kent, family physician, and we are going to continue the physical examination and look for more focused physical findings in a segmental region for our patient's myofascial problem. Dr. Wolfson, who gave the last lecture, has a father who was an orthopedic surgeon in Israel, and he told his son Simon, if the patient didn't get undressed, you didn't examine him. It's really important in our physical examination to have a patient disrobed, and it never fails to amaze me how quick the patient is to acquiesce to my request when they know that they have felt that I felt where their pain problem is. Usually when we're looking for a pain problem, we think of the usual redness and swelling and heat. It's a translation from the Latin to the English, it's easier for me. But all of these findings on physical examination generally refer to problems in joints and not problems in muscle. And we've established already that inflammation is not a major cause of the problems that we're seeing in musculoskeletal pain. So if we are to diagnose the problem, how are we going to get to it? How are we going to get to a diagnosis? 85% of our diagnosis is going to come from the story that the patient tells us. This is our focused OPQRST of any pain complaint. But this is the most important part of the diagnosis, and we have to spend the time listening to the patient, finding what perhaps initiated the pain, even if it was 25 years ago. That's 85% of the diagnosis. Another 10% is going to come from our focused physical examination, getting up from our seat, going over and actually examining the patient. This leaves us only 5% of the diagnosis, which comes from every other method we have to diagnose a patient's problem. From the imaging to the laboratory, to ultrasound, to EMG, whatever you want. If we're relying on those tests for diagnosis, we're going to miss the problem. Those tests should be used to confirm our diagnosis. The last lecture involved the focused physical examination involving the acronym of ARTN, and how we drum into people to make sure you've done all of those things in your focused exam. I'm going to add in this lecture how to look for segmental autonomic signs as a source or the segmental cause of the patient's myofascial pain. And of course, as we examine the patient, we're hoping that we'll be able to, at some point, reproduce their symptoms. When we talk about palpating a taut band or a trigger point, the pictures are rather easy, but in actual fact, the diagnosis of these taut bands and trigger points in particular can be rather difficult. And this is one of the limitations of the research in myofascial pain. There's not very good inter-rater reliability in the examination. One doctor feeling the patient's the skin is not going to have the same findings as another doctor, apart from possibly the trapezius muscle. This is work done by Bob Gerwin. So if we have a finding of a painful tender muscle, we're going to palpate it. And so our palpatory skills are absolutely essential. Often at the beginning, we're going to do an examination which is not very nice for the patient. And that's because we've touched too hard. We take a listen or a look for a second at how we palpate a pregnant woman's abdomen to see where the fetus is. Our feel is much, much more gentle. We're dealing with a fetus in there. In the same way with feeling for a patient with myofascial pain, often if they have a segmental neuropathy or neurogenic problem, they're going to be hyperalgesic. So our normal touch is going to be painful for them. The key is that more gentle that we are, the more we're going to find. Just think of palpating a vein in somebody. We use a very gentle touch, and it's the same palpation, just a couple of layers deeper, which is going to find a taut band in a muscle. And if we run our finger along that taut band and feel a more firm area, that's what we think of as the trigger point. And that's the place to deal with, to treat. take an example of perhaps the sternocleidomastoid muscle. What's going to happen if we touch that trigger point or feel that taut band? The patient will have a number of responses, from jumping, from raising their eyebrows to scrunching their eyes, to perhaps even groaning. Or if we hit actually upon a very sensitive muscle, the muscle itself will twitch. And these are the positive physical findings in the examination. However, because we are being more gentle, if you palpate the sternomastoid muscle, the anterior component of the SCM, palpation of those various trigger points in the muscle may reproduce the patient's symptoms in their head, because that's the pain pattern of the sternomastoid. And this can be differentiated from the pain pattern of the cleidomastoid underneath it. And then our treatment will be different, and our needle direction for treating will be different depending which muscle we're treating. What are the neurological findings that we're going to have to get into? We've discussed this a bit in the previous lecture. We have to be sure that our problem is peripheral and not central. Somebody with a central nervous system problem, with an upper motor neuron lesion, is not likely to respond very well to treatment of a myofascial problem, whether it's deep dry needling, intramuscular stimulation, whatever you want to call it, or even manual therapies, apart from trying to maintain a spastic muscle a little looser. We need really an intact axonal neuromotor reflex to be able to effect our treatments. If we see that the problem is regional, is the problem a neuropathy? Do we have a problem of shingles? Well, that's not going to react or respond to needling therapy. However, if we have a nerve which is having difficulties, perhaps an entrapment phenomenon, that is very amenable to needling therapy, because on a very frequent basis, the nerve is going to be trapped as it travels along or in between different muscle layers. And muscles, when they're short, are thicker. They're mostly water, and water doesn't compress. So those thicker muscles may in fact press on the nerve and cause an entrapment neuropathy in the periphery, amenable to treatment with the techniques that we use. If we find that a problem is segmental, we're going to have a radiculopathy, and so we will have problems in the muscles affected by that segment. But in that examination, we're also going to look for segmental autonomic signs. And I'll spend the rest of the lecture describing how we see those problems on physical examination. And this is because in a segmental problem, it's not only the motor nerves and the sensory nerves that are involved, the sympathetic chain and the autonomic nerves and the very delicate C fibers which transmit the chronic pain are the ones that are the essence of the problem and the basis for our treatment. And of course, the most common cause of pain is going to be the myotomal problem, the muscle problem itself with its pain pattern, which is going to be expressed in a myotomal fashion and not a dermatomal fashion, which is the way we've learned our nerve distributions up till now. So what about the segmental autonomic changes we are perhaps going to see? We may perhaps see somebody who develops goosebumps on the initial touch. All of a sudden, their pilomotor response lights up. And that is a positive physical finding of a supersensitive hyperresponder with a pilomotor response. This isn't a person's buttock we're looking at in the picture, it's their left arm. And on the left-hand side, we see the goosebumps on the skin immediately adjacent, above, below, or perhaps the other arm. We won't have that finding on the same stimulation of the subject. A pseudomotor autonomic response will be findings of sweating or dryness of the skin. Pass our hand down the patient and all of a sudden they're soaked or my hand is soaked. That is a significant segmental finding of a change. And that will lead us to our diagnosis and then our treatment. Passing the hand down the body gently, either with the back of the hand or the front of the hand, we'll find differences in heat or cold of a certain area. If we feel heat, yes, we think of inflammation. But now our examination includes, does that part feel cold? Is there in fact a difficulty or difference in the arterial tension or the lymphatic flow back to the body, and therefore increased coolness of the area which is involved. And then the discussion of trophodema, which is generally a new topic. How do we see trophodema in the patient, in vivo? Well, what Dr. Gunn is doing with his fingers on the patient right now is a simple skin rolling test. As we roll our skin down the back, the patient shouldn't have a problem. But here we see in the photograph, Dr. Gunn has found an area where the skin doesn't roll. It is much more sensitive for the patient, and the tissue doesn't have the same turgor, the same texture. It's tight there, and that is a local swelling, edema, which is superficial, subcutaneous, and doesn't allow the skin to roll. Another test which we can do is a gentle pressure and then pushing on the skin a little up. Dr. Gunn's left finger shows we can see the pores more easily. On the right-hand side, that's not happening. Well, that's a peau d'orange effect. Now, we've learned that peau d'orange is a problem of inflammatory carcinoma of the breast. Well, what's the basis of it? A problem with lymphatic drainage of the breast because of the carcinoma. Here, of course, all we have is an autonomic segmental finding where we have decreased lymph return and therefore increased congestion of the subcutaneous tissues. And that is a positive physical finding. Another simple, very inexpensive test is the matchstick test. Taking the back end of a matchstick and pressing it on the skin gently for a second or two, then removing it and doing it in a number of places. And we'll see on a segmental basis, a portion of the skin will have persistent marks just from the needle butt or even from the back of a Q-tip. And that'll be at one area of the body, one segment, and not above or below, not on the other side of the body. This is an area of localized trophic edema, trophodema, congestion of the skin. We often rely on the radiologist's findings. Take a look at this horrible neck with its spondylosis and oncovertebral joint problems and narrowed intervertebral disc space and all the black markings of a person with horrible problems, perhaps. The radiologist doesn't have the benefit of the patient sitting in front of me, and this is the patient. And look at her neck with the skin creases there. What are we seeing? We're seeing two things. One is the thickened trophodemic cervical tissue, and the other is that the multifidi, the intervertebral multifidi, which are shortened, are pulling those vertebrae closer together and causing the skin to crease, just like a tablecloth. Now, of course, there are many people with lots of skin creases, and even my children have those skin creases. This is a problem of potential difficulties. The thing is that I wouldn't want this lady to get into a car accident and have a whiplash injury, because she already, we can see, has a predisposition to a problem there, and an ongoing chronic problem. Or perhaps this person is suffering from a tennis elbow or a repetitive strain injury, carpal tunnel syndrome. The cause is coming from the neck, and treatment of the neck is sometimes sufficient without treating the periphery, sometimes sufficient to treat the problem. So we're looking at a segmental pattern, and it's very important to remember this is not the Frank Netter diagrams or the other 5 or 6 methods of looking at dermatomal distributions of nerve innervation. We're looking at a myotomal or a fascial innervation. The picture on the right shows a patient's subscapularis muscle with pain often being found lateral to the scapula as we start seeing the subscapularis coming out. But look at the back of the wrist. How do you explain that referred pain down to the back of the wrist in a watch-like distribution? It's very typical of a subscapularis problem. Patient who comes in saying it really hurts here, but when you press, it doesn't hurt. go to the subscapularis, press on it, and all of a sudden it reproduces the person's pain in the back of their wrist. That's phenomenal, but it's not dermatomal. So in the 1940s, Dr. Inman did some studies in the recent past that has been questioned a little bit, but basically looking at, say, a C6 distribution, our usual thoughts of a dermatomal pattern will look for a C6 innervation on the wrist, or on the back of the hand, radial aspect. However, C6 is also, in its myotomal innervation, innervating the pectoralis major. C6, in an osteotomal innervation, innervates the medial aspect of the elbow. And so this gives us another place to hang our hat where we're looking for the reasons behind the findings we have on our physical examination. So looking overall, to try and wrap things up, probably a spondylotic problem is a probable cause or factor which may lead to the development of problems in innervation of a segment. When a segment such as the upper arm is involved, we're going to end up with shortening of muscles, and that is going to lead to a problem either there or further down of a muscle or a nerve which is caught and causing the problems in the periphery. And this is the idea of a shortened muscle causing the problem. When we feel the muscle, the normal muscle will be relaxed, long, and loose. A abnormal muscle, a sick muscle, is going to be shorter. It's going to be fatter because it has to swell if we're making it shorter. The tendon will be thicker, and we're going to see an enthesopathy, perhaps, in the tendon. And in the muscle itself, by gentle palpation, we may find that we have a taut band in the muscle, or even, in fact, a trigger point which is palpable or causes a twitch and reproduction of the patient's symptoms. So what are the outcomes of these that we'll see in our physical examination? A short muscle may cause a problem at its attachment and cause a tenosynovitis, such as a tennis elbow. It may also, in another person, cause a problem as it passes through the synovial sheath, a tenosynovitis such as de Quervain's synovitis. In somebody else, it may cause a problem as a sesamoid bone like the patella travels over the condyle of the knee. But all of these problems may not be separate with different pathology. They may all be caused by a shortened muscle a little bit upstream from there. And so in treating tennis elbow at the top, we'll treat the forearm muscles to relax them and decrease the tension on the bone. We'll treat the thumb muscles, the extensor and the abductor, in the forearm to relax the muscle and decrease that tension on the tendon as it passes through its sheath. Or in somebody with a patellofemoral syndrome, or even a teenager with an Osgood-Schlatter's problem. Treat the quadriceps, in particular the rectus femoris, and relieve the patient of their symptoms, and that is phenomenal, particularly to see a almost 50% reduction in pain on the spot in your office. It's very gratifying. To use as references for all of this, in my office I use Travell and Simon's book. It's expensive, but it's worth it. It has all of the background behind it. It goes through all of the physiology, a lot of the research from the trigger point hypothesis. Much cheaper and a very good reference is the Concise Guide for Trigger Points by Simeon Neil Asher. He's an osteopath colleague of ours in Israel, also practicing in England and around the world. And he's put together a very good books describing also the pain patterns of each muscle and also methods of treatment, and also take-home exercises for the patient. And it's a book that I highly remember for people who are getting into this, this whole issue of myofascial medicine. The Travell and Simon's books are helpful because they have the maps say you have a person with pain on the front of the chest. What could be the problem? And they go through a listing of the possible muscles involved. And so if I haven't thought of the scalenes as a reason to have anterior chest pain, I look at the map, I feel the scalene, the patient says, oh yeah, that's the pain in my chest. I've reproduced the patient's pain on my physical exam. That's our objective reached. So I thank you very much. I hope you'll fill in the questionnaire at the end of the lecture, and perhaps we'll see you in one of our practical courses. Thank you very much.